Okay, I think we are ready to go. Good morning, good afternoon, or good evening to everyone, depending on where you are on the world. Welcome and thank you for joining us and being here for the 8th lecture of IAPD20 Virtual. Today's parenting styles and the etiology of child behavior in the dental settings. Let me introduce myself again. I am Figen Seymen from Turkey, one of the board of directors of IAPD and also moderator of this session. Before I introduce our very valuable speaker, I would like to cover a few housekeeping topics again. This lecture is being recorded as usual, and if some of you are not able to join, we welcome you to visit the session from the agenda. We also invite your comments and questions. Please look at the Q&A and chat box on your screen in Zoom for the live session. Just type your question in the Q&A box and we will hold it for the discussion portion at the end of the lecture. And we will get to as many questions as time allows. If your question is not answered, write it in HUA in the agenda. And I'm pleased to introduce this session's speaker. It's a big honor for all of us, Dr. Amr Moursi. Dear Dr. Amr Moursi, welcome to IAPD20 virtual meeting. And thank you. You're welcome. Thank you once more for agreeing to present the lecture. It's a very big pleasure for all of us. I want to introduce Dr. Moursi. He's a professor and chair of the Department of Pediatric Dentistry at the New York University College of Dentistry and on the medical staff of the New York University Langone Medical Center and the Bellevue Hospital Center. Dr. Moursi completed his DDS degree at the University of Michigan School of Dentistry, a pediatric dentistry residency at Children's Hospital of Pittsburgh, and then a PhD in craniofacial biology at the University of California, San Francisco. He's a board-certified diplomat of the American Board of Pediatric Dentistry. For the American Academy of Pediatric Dentistry, he currently serves as Vice President, Fellow of the Pediatric Oral Health Research and Policy Center, and Director of the Comprehensive Review course. Dr. Moursi also serves as an examiner for the Royal College of Surgeons in Ireland. In addition, he has led teams of NYU faculty and students to provide pediatric dental training, education, and care to underserved areas around the world. At this time, he also maintains a private practice in New York City. At this time, I'm going to hand the floor over to Dr. Moursi. Dear Amr, it's all yours.
Wonderful. Thank you very much for that wonderful introduction. And I want to thank everyone who's joining us here today, especially those of you who are staying up late in the time zones when it's 12-hour difference. Here it's 12:30 in the afternoon in New York. For those of you where it's 12:30 at night, you're staying up late for some quality pediatric dentistry education. I applaud you. And I also want to really take a moment to thank IAPD for putting this on. These virtual events are not easy to put on. It takes a lot of coordination of time and people and resources and technology. So I really want to thank the IAPD leadership and the staff and Daphne in particular for all she's done. And I also think we need to take a moment to thank our sponsors and Colgate in particular for making this possible. These are events that take a lot of resources and expenses, and without the generous support of our sponsors, this would not be possible. So my thanks to them as well. What we're going to talk today about is behavior guidance for today's parents, and really focusing on kind of how does parenting, especially today's parenting styles, affect behavior of children and thus affect our choices when we look at the options, the behavior guidance options we have available to us. So we'll talk a little bit about that. Before I go into that, you've heard my bio, so I'm not going to go into that. But I'm one of the reasons I was particularly thrilled to speak to this group is I really think that this kind of international scope of pediatric dentistry is very, very important. That's something that at NYU, we do quite a bit. We have a lot of students and faculty from around the world. And we invite a lot of guest visiting scholars from around the world. We also go around the world providing care and education. So it's a big, vital part of what we do. Personally, as you heard from my bio, do quite a bit internationally. I'm originally from Egypt, so hello to all my Egyptian friends who are listening. But also, grew up primarily here in the United States, and it's that kind of perspective that I like to bring to these types of presentations. So I'm thrilled to have this sort of kind of global group with us, especially now, especially everything that's going on in the world right now with the pandemic. As most of you know, New York City for several months was the epicenter of the pandemic, and we were having at times in April up to 800 people dying per day just in New York City. Most of us here living in the city felt that personally. We knew people, many people who were infected and got seriously ill, and unfortunately, some who passed away. Fortunately, we've recovered and we're bouncing back, and things are doing very well here in New York City and at NYU, and it's now one of the safer places in the United States, and we're trying to keep it that way. So another great reason to be able to all come together for these kind of events. As I go through the presentation, I encourage you to try to be in the moment. With everything going on, and nowadays we get flooded with lots of information, whether it's on social media or email. It is hard to kind of resist, especially now on these kind of Zoom platforms. It's hard to resist kind of being distracted by that. So I encourage you to take this next hour, turn off your email, turn off your phone, turn off the social media, and we'll have this discussion together. I promise you about halfway through, I'll give you a media break. You can check and see if there's that really just adorable video of a kitten playing with a horse on Instagram. We'll make sure you don't miss that. But I think it's valuable to take a little bit of time to just focus and take in what's going on in the moment. So behavior guidance, I think, for pediatric dentists it's what we do, right? I mean, if you had to pick one thing that makes us distinctive and distinguishes us from other types of dentists, I would have to say it's our training and skill and expertise at behavior guidance. And a lot of that behavior guidance really starts at home. So for those of us who are parents, we do behavior guidance every day with our children, right? Even if we don't have children, if you have nieces and nephews, family, friends, you interact with kids and you kind of do it instinctively. And most of the time we get it right. We remember how we were guided by our parents and our teachers and other adults. And so we kind of use that when we're dealing with children, especially if we're trying to get children to do something they don't necessarily want to do, or protecting them from doing something that they shouldn't. But there are times when we don't get it right. So I think it's that home edition behavior guidance that we bring to the table, and then now we need to add the science on top of that. And my wife and I, we started with our home edition. This is a picture of our daughter Cleo when she was very young. And see, we started kind of oral hygiene early. That's my wife brushing her. She had, I think, 2 teeth at the time. And then she was a proud Michigan fan. As you heard from my bio, I went to University of Michigan for my bachelor's degree and for my dental degree. So we started Cleo off very young. And then now she actually just a few months ago graduated from the University of Michigan with an undergraduate degree and a master's in public health. So, and that's my wife, Mary. So that home edition behavior guidance, is what many of us kind of bring with us. And we need to now add to that, because behavior guidance, again, is what we do. And why do we do it? We do it because we need it to deal with this major public health problem. We're not going to talk about caries today, other than I think it's important to not forget why we're doing this in the first place. If we can't optimize our behavior guidance, we will not be able to address this huge public health problem. And it's a global problem. Certainly, including here in the United States, you can see the numbers 5 times more common than asthma. And it seems most of the children in my practice have asthma. If you survey parents, #1 unmet health need. And that's, again, globally as well. And it's concentrated, right? It's concentrated in a very small group of people. That is what you'll see is another big part of behavior guidance and parenting. Sure, caries, 70% of caries is concentrated in only about 8% of children, in preschool children. And it has to do with economics and the education level and income level of families, health, access to healthcare, that sort of thing. But it also has something to do with parenting. And we'll talk about that in a moment. I won't go through all these, but I think it's always important to remind ourselves that it's not just teeth, right? It's not just baby teeth. As we hear from parents all the time, they're going to fall out anyway, so what's the big deal? Well, as we all know, it impacts all parts of life. And many of these affect both the family, the parents, siblings, as well as the child in question, the patient. And not to mention that child when they get to be an adult. So I always try to kind of keep that in mind when we're talking about behavior guidance, because I think sometimes it's easy to lose sight of, okay, you know what, we need to master this. We need to have a whole toolkit of behavior guidance techniques so that we can stay on top of this very severe problem of early childhood caries. When we talk about behavior guidance, there's a lot of decisions that have to be made very early on. Like with pretty much everything we do, we have to look at risk versus benefit. Whether we're doing sealants or extractions or general anesthesia or simple tell, show, do, there's always risk benefit involved. And I think lots of times we maybe lose sight of that a little bit when we're thinking about what our options are. Ultimately, we need to pick what's the best behavior guidance technique, behavior guidance approach for that particular patient, for that particular moment. And sometimes I think we think, well, we just got to get this done. Hey, look, the parent took a day off of work, they took the child out of school, they drove 3 hours to get here, we need to get this done. And sometimes that's not necessarily the best for the patient. Sometimes it's best to defer or do something that's maybe not definitive and then bring them back. Hopefully, we're thinking of what's in the best interest of the patient. And sometimes you have to advocate for the patient because the parents actually are the ones pushing for something that may not be best. And that's not easy always to do. But I think keeping that in mind, that risk benefit and what's the urgency. If this is a true emergency, then obviously things have to get done. But if it's really not an emergency, I think hopefully we've gotten beyond that, hey, look, this is the treatment plan for today. We're going to get this done no matter what. Certainly during my training, there was a little bit of that. There was, hey, look, it's you against the child. And if the child's uncooperative or if there's other issues and you don't get that treatment done today, then you lost, the child won. And it shouldn't be that way. It shouldn't be a battle. We should be looking out for their best interests. So thinking about kind of what's the consequences of deferred treatment. And nowadays we have a lot of other options, whether it's with Hall crowns or silver diamine fluoride or glass ionomers, ITR. not going to go into all that, but I think it's important to take a moment to think about when we're making those behavior guidance decisions, what's really best for the child in this moment, and also long term. The idea is to build a dental home, right? Not just get that stainless steel crown done today. It's to build a dental home where the child and the family feel comfortable coming back again and again, to build that good kind of comfort level with oral health, not just now, but in the future. A lot of factors that go into child behavior. Not going to go through all these today, but we'll touch on a little bit of some of these: parental expectations, parenting style, temperament, but there is a whole host of other, obviously their medical history, if they have any disabilities, cognitive disabilities, if there are any medications. Many medications affect behavior. Also the microbiome. There's a huge amount of literature showing that the flora in and on our bodies actually can affect how children behave. That's another whole lecture, but so it shows you it's not just a simple kind of black and white. Well, this child has good behavior, this child has poor behavior. There's a lot of different factors that come into that, and we need to assess those factors as we're deciding what's the best approach to take with that particular child. Once we do make this assessment, and maybe we make then a decision, then now we have to think about, well, how do we now make sure it's accepted by families and parents and make sure it's effective? And the changing family structure plays a big role in that. If you look at the literature over the years, what parents will accept as far as behavior guidance techniques has really changed and evolved over the years, with the changing in parenting style, but also changes in what we define as family. For example, right now in the United States, only about 65% of children live with both married parents. That's very different than, say, even just 20, 25 years ago. 62% of low-income children live in a single-parent home. And 41% of children are born to unmarried mothers. That's about 1.5 million children per year. Now, you can argue whether that's good or bad or right or wrong. That's not the point. The point is, these are the patients that are coming into our practices, into our clinics, into our hospitals every day. And so we have to take into these family dynamics into account when we're trying to make sure these choices are accepted by families. Because layered on top of that, you have cultural differences, religious differences, language issues, and there may be multiple caregivers, multiple guardians, whether it's the mother, the father, the parent, the grandparents, if the parents are divorced. So all this plays into what's going on with our choices. These choices get even more complicated once you get into more of the advanced techniques like sedation and general anesthesia and stuff, where it's really important to make sure you get good consent, and that consent is an informed consent by the true guardian and caregiver. So before we talk about kind of parenting style and how parenting style affects behavior, where does this behavior come from? What determines how that child is going to behave today? So little Susie is coming in for a stainless steel crown. She's 4 years old. What determines whether she's going to be cooperative or not? What determines how she's going to react to that situation? Well, it turns out there's a lot of science behind this in the child psychology literature. And a lot of this was new to me. I didn't really get much of this in my training. And I think only now it's slowly kind of getting into the dental literature and the dental field. We'll touch on a few of these elements that have been studied well by the psychologists, and really are very relevant to kind of what we do every day in our pediatric dental practices. So we'll talk a little bit about temperament, temperament of the child, talk about parenting style, attachment, how a child usually during infancy attaches to their parents. Certainly cognitive development is part of that. We won't touch too much on that. And then their fears. We deal with the fears every day and trying to how do we overcome those fears. So given all these different elements that can comprise the what makes up a child's temperament, we talked about their socioeconomic situation, their culture, their family dynamics, their income level, education level. Given all those different factors, it's kind of hard sometimes to determine, well, what truly does determine a child's temperament. So what we'll do is we'll start with a poll question here. And this question really relates specifically to temperament. And we're going to talk more about temperament, but just before we dive into temperament, let's just get a sense of what you all think are the key factors that determine that temperament. So we'll launch the poll here. We'll give you a few seconds to select what you think is the right answer. And then we'll try to actually share those results with you. So a child's temperament is primarily determined by socialization, genetics, attachment during infancy, parenting style, or all the above. I will give you just a few more seconds to pick your favorite answer there. All right, and so now we'll see if we can launch the results. And in the meanwhile, there we go. All right, so most people picked all the above, and you can see there's a scattering of the 4 other choices. I gotta tell you, this was done kind of on purpose to be a little bit tricky. The correct answer is B, is genetics. So that comes as a surprise. It certainly came as a surprise to me. But why is that? So let's talk about that a little bit. Here's the temperament traits. I won't go through all of these, but this is where the child psychologists kind of break down the various traits that make up a child's temperament. You can see many of them have a lot to do with what we do every day, certainly adaptability. We rely on a child to be pretty adaptable when they come to a dental office, especially if it's their first visit to a dentist or the first visit to your particular office. They have to adjust to a lot of changes, new sounds, new people, new smells, new sensations. Are they moody? Is this someone who's kind of on a pretty even, steady keel, or are they up and down? What's their sensory threshold? We throw a lot of new things at these kids. How much can they take? And those of you who've been around kids know that some children can just take in and cope with a lot of new sensations, where others, they get overloaded, and then that becomes much more difficult for them. So taking into account all these traits, the psychologists have divided children up into 4 major groups. Those who are easy temperament. So these are ones that are quite adaptable. They're not moody. They have a high sensory threshold. They can take in a lot of things without getting too upset. Then the next category is the cautious child. They will eventually get there, but they can be a little bit more fussy, don't deal with a lot of new sensations all at once. But with a little nurturing, a little hand-holding, they can get there. Then there's the kind of what they call the difficult temperament patients. It seems like most of the patients who come into my practice are this difficult category. And I'm sure many of you see this as well. And by default, right, most children are seen by general dentists. And so who are going to be referred to us? It's going to be very often the children with this difficult temperament. These are the ones who are very moody. They're not adaptable. They don't have good coping skills. They don't handle a lot of new sensations very well. Their sensory threshold is pretty low. Fortunately, most children are in this kind of easy category, but there's about 10 to 15% that are in the cautious and difficult. But again, we're going to probably see a much higher percentage of that. So taking into temperament, well, how does this relate to parenting style? So this is where we need to think about how the genetics relates to this. So the answer to that question, what determines temperament? Well, the feelings that these children have, and these these instinctive reactions are genetic. And it turns out the literature shows that there's a number of candidate genes that have identified for this that say, hey, look, you know what? Your temperament is pretty much hardwired. That if you are one of these kind of easy temperament children, you're going to be that way pretty much for your entire life. You may have good days and you may have bad days, but overall, on average, it's unlikely that an easy child is going to switch to a difficult child or vice versa. And certainly transitioning a difficult child to an easy child in a 30-minute pediatric dental appointment is unlikely. So I think that's a big concept to wrap our heads around, because I think many of us feel that, hey, look, you know what, given the right circumstances, I can roll up my sleeves and I can get even the most difficult, most uncooperative child to cooperate and get the treatment done. I think once we realize that, not all children are just going to kind of melt in our hands once we use our clever pediatric dentistry behavior guidance techniques, then I think we're still going to treat them and we're still going to manage them, but we're going to do it more appropriately and I think with a lot more efficiency. So that's a big concept to kind of comprehend, is that temperament is hardwired. And so if we say that the temperament's hardwired, then how does parenting style affect that temperament? That's where this dandelion and orchid theory come through. And I particularly like showing this slide because I get to show off my picture of these lovely orchids that I took in the famous orchid garden in Singapore with my good friend, Dr. Monty DeGaulle. But it really is a great an example of how how genetic factors can affect behavior. And I won't go through all these, but this gives you a sense of all the genes that are involved that have been identified. And really what it works out to is there's a number of genes that I've identified that make a child highly sensitive to their environment, and in particular to their parenting environment, to the parenting style that their parents have. I think this graph kind of shows it the best. So you can see here on the vertical, that's child's behavior from naughty to good. And on the horizontal, parenting style, kind of parenting effectiveness from worst to best. If you look at this pink line here, these are children that have what they call many orchid genes. So these orchid genes are what will make you highly susceptible to your environment, particularly your parenting environment. So these children that on the pink line have a lot of orchid genes. So you can see here, if a child has a lot of orchid genes and they're in a situation where they have very good parenting, their behavior is going to be excellent. They're going to be superstars. And they follow these children ages 5 to 17, over 400 of them, and they followed them for 12 years. They started at age 5 and followed them for 12 years till age 17. And they looked at all sorts of things: how they behaved at home, how they behaved in school, how well they made friends, did they get into disciplinary issues as they got older, did they get into some of the adolescent problems, smoking, drinking, drugs, violence, crime. So they looked at a whole slew of behavioral outcomes. And they found that if you had a lot of orchid genes and you had good parenting, you were going to be a superstar. But on the flip side, if you had poor parenting, the parenting environment was what they call worse, you were going to really have problems. You were going to have a lot of behavioral issues. As compared to what they would call a dandelion. A dandelion is a flower that, it's not the prettiest of flowers, but it can grow anywhere. It's very resilient, right? It can grow in a pristine English garden or on the side of the road by the highway. These children, these dandelion children, have very few orchid genes, no matter their circumstance, no matter their parenting environment. They do about the same. Again, the orchid children, they have many orchid genes like an orchid, boy, if you give them just the right moisture, just the right sunshine, you sing to them, you give them the right soil, they are going to be superstars. But if you don't, that beautiful specimen is just going to wither and wilt and die and give you this just brown, wilted, dead flower. That is kind of the analogy between the dandelion and the orchid. The orchids are not very resilient, whereas the dandelions are. So if we keep that in mind, we say, okay, well, temperament's hardwired by our genes. The children's susceptibility to parenting is determined by genetics. Well, so what is this about parenting? Well, parenting styles are broken up into kind of these 4 areas by the psychologists. Authoritarian, these are really strict parents, but with very little sensitivity, very little empathy. Authoritative parents are parents that are kind of the ideal parents. They're firm, they have high expectations, but they do it with kindness and understanding. Permissive parents, we've all seen these, right? Like little Susie is running the show here, right? And they set very, very few rules, very few expectations. Uninvolved parents are fortunately very rare. That gets into kind of area of negligence. Classically, these parents have been divided up into these 4 areas, and you can see some of the traits of these parenting styles in what's called Baumann's parenting typology. So this is kind of how the psychologists look at this. And it's not just a purely academic, psychological exercise. There is true world health consequences. So you can see here in this particular study, children of authoritarian mothers, so these are the really harsh, unsympathetic types of parents, were 5 times more likely to have overweight children than children who had authoritative mothers. So here's a direct link between parenting style and something as important as childhood obesity. Also in oral health literature, you can see authoritative parenting. Again, these are the ideal parents. Their children have a reduced risk of caries. So you can see how there's these direct links. Parenting style has evolved, obviously. So those 4 major categories are kind of the classic categories, but there's a lot of subcategories to those. And especially here in the United States, there's quite a few different ones, and we won't talk about all of these. But you've probably read about some of these online in the news. The idea of kind of being a helicopter mom, where helicopter parents are just constantly hovering over their child, trying to do everything for them and making sure their life is just as seamless as possible. Or this idea of being a bulldozer parent, where you get out in front of your child and you just bulldoze away anything that could potentially be stressful, and make sure that they just have smooth sailing. In many of these cases, this kind of overparenting is usually not successful. It's usually has some downside to it, and in general, but in specifically situations where they come to our office and now we're trying to get them to do something that's maybe, yes, a little apprehensive, that they may have some apprehension about, that is a little scary, then we have to manage these kind of parents. And that's where understanding these parenting styles really comes into play. Now, you got to take all this with a little bit of grain of salt, because I think if you look back, every generation thought the previous, the next generation of parents were much too lenient, right? I'm sure my parents think that we're too lenient. I'm sure we'll think our daughter will be too lenient. But there is actually some good literature showing that there really has been a quantum shift, that there really has been a generational shift in parenting. And the question is why? Why now? A little bit of insight comes from some of the demographics. You can see, at least in the United States, first marriages for women came much later. So, for instance, in 1970, it was around age 21. In last year it was around 28. 7-year difference. That's huge when you look at it at the population scale. Age of first birth, age of the mother when they had their first child, also jumped from 21 to 27. A big jump. And then number of children per mother went from 2.5 to 1.8. So what does that mean? That means that it's certainly much easier to be a helicopter parent when you have 1.8 child versus 3 or 4. And it's certainly much easier to do that when you're older, you're more mature, you're more settled, you're probably more settled in your career if you're working. All these elements come into play when we look at, well, why has helicopter parenting, why has bulldozer parenting come into play now and not 10 years ago or 20 years ago? Now, there are some benefits to this. It's not all bad. You can look at some of the statistics looking at spending per child. Certainly has increased, especially among high income, but also among the middle class. So these kind of older parents with less children are spending more money on their child, whether it's for healthcare or education or just toys. But that's a good thing, right? How about time? They're also spending more time with their children. So those are some benefits of these changing demographics. But there's certainly a downside. So some of the negative consequences, you can see some of the statistics here. The percent of pediatric patients who are diagnosed with anxiety has really skyrocketed. The number of female adolescents, teenagers who are reporting major depressive episode, not just, I was kind of feeling a little down yesterday, but a major depressive episode jumped dramatically. The number of college students who freely admit that they have a psychological disorder increased, and that's probably underreported. And even something as extreme as suicide has doubled since 2007. Is this all the parents' fault? Not necessarily. There's a lot of other things going on in our societies, but there has been some suggestion that this overparenting can play a role with this. So we've talked about these statistics. Well, exactly why? If you have this overparenting, the literature shows the children are going to have higher anxiety, higher depression. They're going to be much more self-critical. They are going to report less satisfaction with their lives. They're not going to have the same level of peer attachment. They're not going to have many of the coping skills they need, the confidence they need. A good example of this is going to the playground. This is not a poll question, but just take a moment to think. Try to remember how old were you when your parents let you go to the local neighborhood playground by yourself, let you walk there and back and play on your own? Okay, think about it. If you have children, think about when did you start letting your current children go, or if they're still young, when do you think you feel comfortable sending them? Okay, give that a thought. Well, right now, the average age is about 10 years old. So most of today's parents will not let their children just go, even if it's a couple of blocks away, a 5-minute walk from their house to go play at the playground. In 1970, that was 7 years old. So 3-year difference, again, at the population level is quite dramatic. People are trying to address this issue, and this is, I think, a really great example of this. This is a playground of sorts in New York City, and it kind of looks like a junkyard, right? There's just a lot of spare stuff kind of that just was pulled out of the trash. And what it is really is a place for children to play. You'll notice that there are no adults allowed here. So these are children that are just allowed in to play and create and be on their own without having kind of those helicopter bulldozer parents with them all the time. This was created in New York, but there's several of these around the world, other sites, with that intention to just let kids have this free, unstructured play that they kind of create themselves, often with strangers. Often these children are not necessarily their friends, they're just people who happen to be there at the same time. And it looks kind of dangerous, right? It looks like, wow, you could do some damage. And I particularly like these two kids here. We'll have a little bit of a close-up, just banging away with these metal pipes. But it turns out they've done some statistics, very few injuries involved here. And it's nerve-wracking for the, there we go. It's nerve-wracking for the parents, because these are the parents. They have to stand outside the fence. And you can tell, you know, they've never let their children just go and just play like this. Now, I will say there is an adult monitor who's in there to make sure no one does anything really super dangerous. But parents are very anxious the first time. After that, then they're much more relaxed. You can see actually off to the left, a lot of parents who do this all the time bring folding chairs, sit down, sit back and have a cold drink or a coffee while their children play. This used to be commonplace, right? For those of us who kind of grew up in a different age, this was pretty common. But this is an example of kind of that over-parenting. And it's not that they're bad parents, but this is what many parents today think is what makes a good parent. And it's not just parents, it's dentists. The dentists believe that there really has been this change. So the psychology literature shows this, but certainly so do kind of dentists' own just anecdotal and perceived view of this. And they'll tell you, they think patient behavior is worse. They think it's because of some of these negative parenting styles and this over-parenting, and their willingness to not, their unwillingness to set limits and discipline, and they feel much more comfortable just having you, the pediatric dentist, kind of set those limits once they come in to your office. There can be extremes to this. We won't really get into this much, but there can be extremes where this can actually lead to very noxious and traumatic family environments. And there's a group here at NYU that does a lot of research in this. And they've done some really, really interesting kind of work showing the connection between stressful family environments and oral health, actually how it directly affects oral health. I'm going to skip ahead a little bit because we're running a little bit out of time, and I want to leave plenty of time for questions. So we'll take this slide and we'll go on a little bit. So to try to kind of close the loop on this, we talked about temperament is hardwired, determined genetically. Your susceptibility to your parenting, to your parents' style of parenting is also genetically determined, depending on those number of orchid genes you have. So how does that come together? Well, the psychologists call this goodness of fit. So ideally, you have a child with a temperament that is ideally fit, that is suitable, that is compatible with a parenting style. So if you can have a compatible parenting style and temperament, then you have a great goodness of fit. But we all have seen instances where that doesn't happen, right? And we see it all the time. We see it in the grocery store where there is a child who is just having a meltdown and the parent is just uninvolved, just kind of not doing anything, just really complacent about it. We see the opposite too, right? Child's having a meltdown and the parent is yelling and screaming and sometimes hitting the poor child. So these are typically not just one-offs. There's an issue where the parent and the child don't have that compatible temperament and style. So you can envision a child who's very cautious, right? That cautious temperament. But the parent is one of those kind of authoritative, very harsh parents. And they say something, hey, I want you to clean up your room, or hey, I want you to go and play in the playground with the other children. But the child's a little cautious, a little shy, a little tentative. They get frustrated very easily. Why aren't you just going? Why aren't you doing this? That's an example of the parenting style not fitting the temperament. We see that in our offices all the time. the child is very anxious, very angsty, very kind of just untrusting. And the parent is berating the child right there in your dental chair, right? Say, just hold still, be quiet, let the dentist do it. Why are you? And that is an authoritative parent that is being very harsh and very unsympathetic, lacks empathy for this child who has a temperament that is kind of cautious. Now, are we going to change that? No. As one of my mentors used to always say, we're not here to practice social engineering. We're in this 30-minute appointment. What we're going to try to do is first be aware of that, assess that, try to say, okay, what kind of temperament do I think this child is? And what kind of parenting style do I think this parent has? And yes, this is genetically determined. We're not going to do genetic analysis on every patient that walks into our office, at least now, someday maybe. But we can look for some of these traits, right? We're pretty good. Just a child sitting out in the waiting room, we can usually take a pretty good guess. Are they easy, cautious, or difficult? How they interact with their parent is a pretty good indication of, is this a really harsh parent? Is this a really understanding parent? Or is this a very permissive parent? Once we make those assessments, then we can decide, okay, is there a goodness of fit? If there is a goodness of fit, for example, this could affect our decision whether or not they come in the operatory. If there is that goodness of fit, then the parents should support the child and would be actually helpful to be in the operatory. But if there isn't a goodness of fit, that may be a parent where it's best for them to stay on the waiting room. So that's an example of where making that assessment can directly affect our choice in behavior guidance techniques. So let's skip forward here a little bit so we can make sure and leave enough time for questions. And we'll just wrap it up with a little bit on language. Language starts quite early, and it really is based on our environment, and our environment is primarily our parents, right? When we're very young, the sound recognition, the literature shows, can happen in the first month. Infants, babies, can differentiate between their mother's voice and another woman's voice. They may not understand kind of exactly what the words mean, but they can pick up a lot of facial recognition and non-verbal language. So this is what starts the development of language. And it really is something that's cumulative. So when you read to an infant, you hear all these recommendations. Read to your a 6-month-old baby, read to your 9-month-old. It's not because they're going to understand that Dr. Seuss book, but it builds their linguistic ability. So it actually triggers their speech centers in their brain. Yes, a 9-month-old isn't going to speak, but that's how their speaking center in their brain starts to get ramped up and learn and make all those neuronal connections. So when they do come to speak, they're ready. You can see here, here's just kind of some general rules of thumb that we all use. And we need to be aware of kind of these speech delays. A lot of parents, again, this goes to the overparenting. Sometimes they're so busy overparenting that they don't pick up on some of these subtle things where they may have a language delay, speech delay, sometimes it's hearing loss. So these are good things to kind of keep in mind. But the effect can be cumulative over their early years and can be substantial. So let's go to our last question. This is a poll question that has to do with this kind of idea of building your language skills and language development and where it comes from. So how many fewer words do you think a child from a low-income family versus a high-income family here by age 3? Again, we talked about parental environment, parenting style, socioeconomic status. These all affect how a child develops. It affects their temperament, certainly, their fears, but it also affects their language development. So just we'll give you a few seconds. Is it 1 million, 3 million, 6 million, 10 million? None of the above. These are, again, the difference in the number of words that a child will hear in the household, whether they live in a high income versus low income family. Okay, so we'll close it out and then we'll launch the results. So this comes from a study where they put little microphones on little children and they monitored them over months and months and months. They use this special software and to scramble it for privacy. And you can see here, the correct answer is actually none of the above. And it seems like, wow, well, 10 million. The actual answer is 30 million. And that's hard to believe. When I first saw that, I thought it was a typo. That has to be a mistake. But this study shows where they put these microphones on, they scrambled the actual audio so to protect people's privacy, but they found that a child in a low-income household heard 30 million fewer words over those first 3 years of life. And that is when those neuronal connections get made. That's a direct example of parenting, the style, the type, the effectiveness of parenting directly affects the development of a child. And that is going to affect how we deal with them in our practices. Because if they have poor language development, that's what we use, right? Even if we're sedating a child, even if we're papoosing a child, we are always using our language. And certainly tell, show, do, and distraction, everything we do relies on language. So here's a direct correlation between parenting, language development, and how they will react in our offices. Great. I'm going to wrap things up here with just a couple of thank yous, and then we'll take some questions. Let's find that here. Yeah, so in summary, we talked about risk-benefit. Try to customize your approach. Make that assessment. What kind of temperament does this child have? What kind of parenting style do these parents have? Is there a goodness of fit? And then use that information to decide which of our many behavior guidance techniques would be best for that patient and that parent. And sometimes you have to be the advocate for that patient. Some of what I showed here is from our book, and I like to thank all the contributors to this book, because we use some of the material in this book, and I certainly didn't create this book on my own. We had many, many great contributors from around the world. So I always want to make sure and acknowledge those who contributed to that, and when I use it in my presentation. And if those of you are interested, the publisher has offered a discounted rate. You can see the code there on the bottom. If you want to use that code, you can get a discount when you go to wiley.com. Also, as Vice President of the American Academy of Pediatric Dentistry, they would probably revoke my membership if I didn't send you greetings from the American Academy of Pediatric Dentistry. Wonderful resources at our website. We have a number of courses coming up here. The first 3 are virtual. And are going to be just right around the bend starting this next week. We're also going to be presenting at the Greater New York Dental Meeting. It's still planned to be a live meeting. We'll see if that still actually happens. But if anyone is in the New York area or wants to or can travel to New York, the AAPD will be having some presentations there. There is a lot of the courses, if you can't go in person or if you can't attend them live virtually, so to speak, you can get them at the Passport online portal. Also, all those AAPD events are discounted if you're a member. So there's a number of membership options here, and particularly the International Colleague membership. That's a new membership category that was just created in the last couple of years. If you are in the designated World Bank category, and you can look that list up. I was recently in the Philippines, and they certainly qualified. It's $100 US dollars per year, and you get all the benefits. So that's a new category, and I highly encourage international students as well. A lot of benefits from this membership, so it's something to look into. Lastly, these are some of the resources that have information on some of what I've talked about today. You're always welcome to come by NYU and visit us. We have this new disability center this is the OR with a view of the Empire State Building there. We'd love to show you around if you're in New York. And if you're not sick and tired of hearing me talk and you want to still hear more, you can tune into my radio show. That's the first Monday of every month on Sirius XM satellite radio, Dr. Radio Channel 110. And this is the first Monday of every month, 3 p.m. New York City time. I want to thank you very much. I really appreciate everyone attending. And again, I want to thank the IAPD and our sponsors for being able to put on this wonderful IAPD20 virtual event. Thank you.
Thank you very much, dear Dr. Moursi. It was really very informative and excellent and different style. It was great that you included the participants with the poll questions. Now we will go ahead and take some time for questions. First question, what is the role of childhood adverse conditions in the children's temperament and behavior?
Could you repeat that one more time? I'm sorry.
What is the role of childhood adverse conditions in the children's temperament and behavior?
Yeah, and I didn't have time to get into that, but again, there's a lot of literature on that, and in particular from our group at NYU, which shows, yeah, even if you have just a couple of adverse events, especially in kind of the early childhood when that neuronal connections are being made, it can have lasting effects on your ability, especially to cope. So some of the studies looked at actually infants. A lot of the thing is, well, hey, look, you know, if you're a child living in a single parent home where there's low income, poor nutrition, poor health, there's violence, there's drug abuse, there's physical abuse, then that's going to affect you, especially if you're a little bit older and you can kind of, you're aware of what's going on, but probably wouldn't affect the 6-month-old baby. It turns out it's actually the opposite. Though they may not comprehend exactly what's going on, that's when a lot of those neuronal attachments and connections are being made in the brain. And if they're not made adequately and in enough quantity at that age, then it's really hard to catch up later on, and they end up having a lot of behavior disorders. So that's why getting a good social history is really important. So you get a sense of what has this child's life been like. And those are sometimes sensitive questions to ask, but certainly there's markers. If a child was in foster care, that's often an indication that there may have been some of those adverse events. If they're being cared by someone other than the parents, then sometimes that's an indicator to dig a little deeper. You know, why is not the mother and father not involved? Were there some adverse issues? So it can have some direct effects for sure.
Thank you. I want to combine the two questions together. How significant is the temperament gene between siblings of the same family? And the other question is, how two types of temperaments of the parents affect their kids? For example, if one parent has different temperament than the other.
Yeah, I'll take the first part first. Yes, siblings can have very, very different temperament and very, very different numbers of ORCID genes. So, and we see that all the time, right? How many of you are just really different from your sister or brother, right? There's a whole host of reasons for that, but certainly the number of ORCID genes you have, it plays a part in that. Now, so you have siblings of different temperaments, and then you have parents with different temperaments and different parenting styles. So that can be complicated, and that's something that we try to assess. We should try to assess all the time, because boy, you know, you'll see some parents where one parent is just really harsh, that very kind of authoritarian, kind of unempathetic parent, where the other one's a little bit maybe at the other extreme, very permissive. That can be very volatile, and then the child gets in the middle. That's when you need to make that assessment and say, look, okay, at least for this dental visit, here's what we need to do, and maybe separate the parent from the child, maybe separate the parents, have discussions with them, because you need to be an advocate for the patient.
Thank you, dear Amr. A lot of questions are coming. I want to choose with the most liked ones. With the helicopter parenting and parental preference shifting towards pharmacological management, do you think non-pharmacological behavior guidance still hold good?
Yeah, I mean, this is going to vary from country to country, obviously, and all the different regulations involved. But, I think parents in general are seem to be less comfortable with things like papoose, voice control, any kind of restraint, and seemingly actually more comfortable with sedation and general anesthesia, at least in the United States. I think, although they, acknowledge the kind of the risks involved, they also don't want their children to be anxious, apprehensive, stressed, and they feel that these kind of pharmacological methods can be a way to avoid that. So I think there's still going to be a large role for pharmacological methods. But we're probably going to really need to, on the other end of the spectrum, work more on working with these parents and kind of making sure they understand, hey, look, here's what's involved. I think simply saying, hey, look, this is how parents are, and we just now have to kind of accommodate them is probably a mistake. I think we need to set the ground rules in a very conscientious and civil way, but we need to set the ground. This is what we think is best for your child, and not feel like, well, we just need to accommodate every whim and every. I had a parent who said, "Hey, look, my child's very anxious. I want to come. I want to show up at the lobby. Our office is on the 6th floor. Show up in the lobby, go straight up the elevator, through the waiting room, and right into the dental chair without stopping at all. Because if we have to stop for a moment just to wait for the elevator or in the waiting room, he's going to get anxious and apprehensive, and we just can't have that." Now, that's unreasonable, obviously, right? So I think we need to feel confident enough to say, hey, look, this is how we practice here, and set those ground rules and not feel that we have to accommodate every kind of whim, especially when they're unreasonable.
Thank you very much. Again, I want to mix some questions together because we already finished our time, but maybe 5 minutes we will continue. Do you have a special form to analyze the parent? And are there any scenarios where you would decide that it's best for a parent to wait outside the room while a child has their treatment? And how would you sensitively convey the message to the parents?
Right. So the first question is, yes, there's a number of forms that people have developed that kind of like we do Carey's risk assessment. It's kind of a behavior risk assessment. And it looks at many of these things we talked about. And it asks some of the common things that we all ask. Hey, how does your child do when they, go get their haircut? How do they do when they are at the pediatrician? How do they do when you drop them off at school? But it gets into a little bit more. So there's a number of those out there. A lot of us just kind of use our gut, and we do a lot of this instinctively. But if you can document it, it certainly helps, especially if you can, some of this can be done before they even come in. You can train your staff to ask just 3 or 4 key questions, and then that can determine, wow, do we need a long appointment or a short appointment? Do we need to have a special room set aside? Do we need a certain kind of additional staff? Should this be in the morning or the afternoon? Should this be a visit where they just come in and look around and go home, as opposed to actually getting treatment? So some of this assessment can be done ahead of time. The second question, I can't remember the second. What was the second question again?
Sorry, I must find. Are there any scenarios where you would decide that it's best for a parent to wait outside the room while the child has their dental treatment?
Yeah, this after all these decades and decades, this is still a controversial issue, right? And certainly here in the U.S., there's really not a lot of I think, consensus. If you look at some of the studies, most parents say they want to be in the room with their child. But if you dig into the data a little deeper, you find that a lot of those parents are kind of telling us what they think they should say. They think that's what a good parent does. Hey, when I go take my child to the pediatrician, I go in with her. So why shouldn't I go in with the dentist? But if you kind of ask parents, hey, look, you know what? Do you really, really want to be here? Your child will be fine without you. They'd much prefer to be out in the waiting room having a cup of coffee in many cases. So I think our job is to make that assessment and figure out what's best for the child. And yes, in my practice, for instance, I would say most of the time the parents don't come in. I can make this assessment and say, you know what? I'm looking out in the waiting room and little Susie is running around throwing toys around the waiting room, and mom's just kind of sitting in the corner looking at her phone. So that mom's probably not going to be terribly helpful in the operatory. And so this is a good opportunity to talk with them and say, look, you know what? I think Susie's going to be just fine. If she needs you, I'll let you know, but just make yourself comfortable here. And 99% of the time, parents are just great with that because you, the doctor, gave them license. You gave them permission to wait out in the waiting room, and you are not going to judge them as a poor parent. So I think there's many instances where we can do the children a big advantage by making that determination and saying, hey, look, you know what? I think it's best. I see there's not a goodness of fit. There's a parent that's very harsh and the child is very cautious. And they're going to need a little bit more hand holding on our part with the dental team. That's a good time for the parent to wait out in the waiting room and let us do what we do best without having to have that parent as a distraction.
Thank you very much. We passed the time, so we cannot answer all the questions. Maybe from the HUA app, they will send the questions directly to you. Yes. Is there anything do you want to cover before I wrap up?
No, I think that's it. I'd be happy to. I'll take a look on the app and answer any questions. But I encourage everyone to kind of think about, two things. One, hey, sometimes we have to defer treatment, and we should look out and advocate for the child. Second is think about that temperament issue that these children are hardwired, and we may not be able to change their behavior and how that's going to affect our choices. I think once you kind of come to terms with that concept, it really does change your approach to behavior guidance.
Thank you very much. First of all, I want to thank you, dear Dr. Amr Moursi, for sharing us your insight, your valuable experiences and knowledge, especially for the poll questions. It was a very big pleasure also for me to meet with you. And sincere gratitude to our Platinum sponsor, Colgate. And dear participants, on behalf of International Association of Pediatric Dentistry, thank you for joining us. I hope we can travel anywhere and meet somewhere on the world in person soon with all of you. Have a wonderful rest of your day and stay healthy. Goodbye. Thank you again. Thank you.
Bye-bye.